I'm Dr. Rick Greene, member of the medical school class of 1970 at the University of Virginia School of Medicine. And it's my pleasure to host this series, which really honors our former faculty, emeritus faculty at the University of Virginia School of Medicine. And today I'm absolutely delighted to be talking with Dr. John Hanks, emeritus professor in the Department of Surgery. John, thank you for being here.
Delighted. Thank you for inviting me.
So I guess the first thing I need to ask you, you went to Princeton, undergraduate, you went to Rochester for medical school. What brought you to the University of Virginia?
After Rochester, I did my surgical residency at Duke, the Department of Surgery at Duke, and I was there from 1973 until 1982. And during my chief resident year, I was looking at jobs in academic surgery. I'd had some background in research and some time at the NIH. And one of my mentors at that time was Dr. Scott Jones, who during the course of my chief resident year was being recruited for the chair to replace Dr. Muller here at UVA. And initially, we were a little chagrined as my chief resident year started, because we were looking forward to operating with Dr. Jones, and he announced he'd be leaving in December. And I figured that was a whole half year. I wasn't going to get a chance to operate with Dr. Jones, who was one of my favorite people to be in the operating room and in the clinic with. And his initial response was, well, Virginia's a very good place, and I'll be gone and I'll be happy to write your letters, giving me a very strong indication that he wasn't interested in me, or there wasn't a spot at UVA. So, that was fine. I was going through my searches and stuff. And Scott came up here in December and decided, I guess, that another general surgeon would be good, and also really wanted to establish a level 1 trauma center. So he talked to both myself and Dr. Sandy Shank, who was a chief resident with me at the same time. And Dr. Shank had a background in trauma. And so long story short, we were both recruited here, me to keep up a practice of general surgery, GI, and endocrine, and Dr. Shank to start the level 1 trauma center. Interestingly, at the same time, Dr. Irving Crone, who's the current chair of the Department of Surgery, had finished his thoracic residency here and joined the faculty, along with Dr. Robert Menser, who had just come back from the military. So there were 4 new young assistant professors kind of all starting the year, and we used to kid Scott about all those slots that he didn't have, but hopefully I think we helped with the department and brought some younger people into the department.
I assume that Dr. Saveston gave his blessing on this move?
More than his blessing. I had looked at, actually Sandy and I, we all looked at some other places, but when I talked with Dr. Saveston, because he had been in the residency with Dr. Muller and they were very close friends, had sort of hinted that this was really the best place for me to go, which of course it was. It was not hard to see that. But yeah, Dr. Saveston was very, I wouldn't say instrumental. Scott was recruited, so he was an interested bystander. He wasn't really pushing or pulling any levers. But at the time we were up here, very quickly we established a lot of relationships with Duke. Med students, fourth-year med students went to the Duke residency. We recruited more Duke people. Dr. Tom Daniel, Dr. Bruce Shermer, Dr. Kexlinghoff all finished their residencies at Duke. So there was this sort of, avenue between Charlottesville and Durham there for a while. So I think it all worked out for the best.
I assume you're a UVA basketball supporter.
Oh, absolutely, absolutely.
Just had to ask.
We were there when Mike Krzyzewski was, there nobody could pronounce his word. My wife, I'll say, because we're in a formal year, my wife has her undergraduate degree from Duke, so she's still an unapologetic Dookie. But after 30 years, I'm a who.
Sure.
Really,
so it's really, you're here, you're part of the department, but it's also Charlottesville. What is it about Charlottesville that attracts people, keeps them here?
It's a number of things. For me personally, I grew up in Washington, D.C., and I had always, I still have a lot of friends there. My parents lived there through the rest of their adult lives. I was very fond of Washington. I always thought that I'd be in the area. So for me, I think Charlottesville, the number one thing is allows me to get back to Washington to see friends and to enjoy the aspects of life that are available. Kennedy Center plays and things, and the Nationals baseball team, which you follow. But it's interesting also that I think Charlottesville itself, I did my residency in a smaller college town. Rochester was not a large city, but I've always sort of seen the virtue of smaller towns or college towns in having a practice that can be a tertiary referral yet still serve a community. So I think that I think that UVA has been a really good choice for me in that area. I can't really speak to being in a big city because I was never practiced in one. Charlottesville itself, I mean, all the alum know the natural beauty of being around this area, and the history is just, of course, fantastic. I never really thought much about the Civil War until I came to Charlottesville, and you're immersed with it, so it's been fun to sort of catch up on the history of the place. So I think there's any of different levels. I think you can have a nice lifestyle. You can be close to the big city if you need to. I found actually I tell people on recruiting trips that one of the real hidden treasures is Richmond. There's lots of really neat stuff going on in Richmond. There's a lot of history. You can be up in the mountains biking. You can be to the seashore fairly quickly. So, and my wife has always enjoyed the area, and she's an explant from California. So it's just, for us, it's worked out well, and I think it combines a lot of good features of having an academic career, raising a family, and being in a high-powered academic center.
Since I'm a surgeon, I'm interested in sort of your surgical philosophy about something. You're trained as a general surgeon. I know that you've transitioned into some areas such as endocrine surgery and others where you built a niche for yourself. I guess the question is, in academic surgery today, do we have general surgeons in academic surgery to act as mentors for students?
Well, if this tape goes on for another 2 hours, we can debate that. It's been, and you've had a lot of input to this. Clearly, academic and private clinical practice of surgery has changed a lot over the last 30 years. And I think that one of the things has been, and I think it's been largely positive, one of the things has been the specialization within general surgery. When I came here, one of the things both Scott and I did, I was very comfortable doing liver surgery, colorectal surgery, major and minor. I felt very comfortable doing esophagectomies and did some of those before Tom Dander came. I felt very comfortable doing that. We had a fair amount of vascular surgery experience. I did not actually do that because there wasn't so much of a need. And as you said, now I look back at my career, and my last 10 years was almost exclusively endocrine surgery. The forces that came into play are the late 80s and 90s transitioned, particularly in academic surgery, where you were looking for the, quote, good general surgeon that could do anything. And those were the referral go-to guys. And then as medicine and surgery began to specialize, the endocrinologists really wanted somebody that really did full-time endocrine surgery. That's what they were seeing, and that's what the referral practice wanted. And I think general surgery went down that area. They went down that area a lot of ways in special certification. It started with vascular, pediatric surgery, and colorectal surgery, and they went into board certification. So we began to specialize in and of ourselves. That said, I personally, I'm an incurable optimist. I think general surgery is alive and well. I think that if somebody really wants to practice general surgery, they do it under the umbrella of what we now call emergency surgery, acute general surgery, where a lot of general surgery will come in through the emergency room or through the clinics that needs to be done not only just as an emergency, but also relatively quickly. And it was interesting, and this was generated by the fact that in a lot of private practices, people who were established had their clinical practices. I had a full clinics and full OR days of my general surgery practice. So if an acute gallbladder came in, an appendectomy, we would have to get it in there or interrupt our schedule to get it done. And so now we have acute care surgeons that have OR time, have expertise, and want to do that. And that is, I think, an emerging area of surgery that offers lots of opportunities in a rural setting, academic setting, or a community practice setting, without becoming a niche, say, colorectal or a niche vascular surgeon. And those people are in demand. I mean, I think that that area of general surgery is very intriguing. I took general surgery call, up to the last year of my tenure, and I always kind of enjoyed it. I didn't mind getting up at 2 in the morning. My wife did, when the phone went off. But you learn a lot about yourself doing those kinds of cases. You learn a lot about the people you operate with, and you learn a lot about how the system works. So I think that anybody in surgery still needs to be able to deal with, emergent type calls, but now with the emergence of the acute care surgery, I think there's a whole different way to really sort of quantitate that and get very good experiences of it.
You became emeritus in August of 2015. What, if anything, have you missed by not being in the operating room?
Yeah. I thought I would miss the surgery. You're kind of saying that I've transitioned out. Before I left, I was involved with a fair amount of administration. I've been president of clinical staff for 6 years, and was probably doing more administration than I really was. Although it was good. I learned a lot. So I certainly didn't miss going to the committee meetings. It was really a lot of fun to resign from all of the committees and say thank you. But you're right. Being in the operating room, I always liked being in the operating room. I think one of the things that people, as they get to the retirement age, need to think about is their stamina keeping up. I would be doing major cases, and at the end of the day, I was getting fairly tired. I'd had major back surgery about 15 years ago, and I really did not want to get back in any back pain. So for me, the time was right, because I could begin to feel that the physical part of it was something, as I got into my late 60s, that I really didn't want to push. That said, I do miss the OR. I do miss seeing my friends between cases and bragging about who did the best case and who did them well. But it's not something that's like altered my thinking or anything. Right now, I've got a number of different hobbies. We've been doing some traveling. I have 2 grown daughters that we visit, and it's been fun. So I've been able to kind of turn a page, yet still be involved with some of the workings of the department, and I think it's fine. I miss probably the most the camaraderie of the residents and my patients and my colleagues in doing what we all were sort of put on the planet to do, is to do surgery. But I don't miss it in a pathologic way, So.
Well, John, one of the things that impresses me about you is your love for organizational work too, and I think we miss that sometimes in our newer generation of medical students and house officers, and mentoring them for organizations that you and I think are important.
Yeah, and that is important. I think that you have to put your time in for either local or national organizations. I have to give a great deal of credit to a real gentleman, a scholar that I met when I came here, that I'm sure that is Les Rudolph, who he and Wally Ritchie were established surgeons on the faculty, full professors, and here comes these little hotshots from Duke, and both of them just couldn't have been nicer and welcoming and saying whatever you need. And they both had a way of saying, well, Hanks, you need to be on this committee, or you need to put your time in doing this. And both of them were absolutely right. And you think, God, I've got, a house and a mortgage and kids, and, I've got to build a practice, and I want to have a practice like Wally Ritchie has, Yet the mentoring is absolutely, I think you hit the nail right on the head, that the mentoring is really important. No matter whether you're in academics or clinical practice, taking a young person and saying, okay, here's the surgery, you know, here's the patient care, here's the community service, here's the organization, and helping them, you know, work their way through that. Certainly, you know, I mean, Les was involved with the Southeastern Surgical that you and I are involved with. And I mean, that was just an avenue for me. It was fun to deal with it. It was fun meeting new people and, you know, helping younger people come through or taking the advice of my seniors. So that was the beginning of it. And then whatever else, you know, committees I've been on sort of grew out of that. But absolutely, I think you're exactly right how important that is.
Well, John, I want to thank you on behalf of the Medical Alumni Association for everything you've done for this university. It's just been a pleasure talking with you today.
Well, you're nice to say. Thank you very much.
Thank you.
Appreciate it.